Okay, cool. Um, so let's actually review real quick. Okay, so if we remember, and we've been talking about, obviously the elbow for the past week. Who can tell me? All right, who can tell me what? So we have how many joints at the elbow, and what do they do?
There's two that do flexion and extension, and then pronation and supination.
Okay, so flexion, extension, and pronation, supination. So here's another question. The ulna, okay, on the humerus articulates with which bony landmark on the humerus? Where does the ulna articulate? You can tell me. Okay, it's the ulna. Forgive my penmanship here. Articulates on which bony landmark on the humerus?
Is it the trochlea?
It is the trochlea. Good job, Bella. All right, so the trochlea. Okay, what about the radius, though? Where does the radius articulate on
the capitellum?
Capitellum, Nico. That's right, sir. Now, here's the crazy thing. All right, you guys are going to see this spelled actually different ways depending on what you're reading, right? So some people may actually spell this, and this is no joke, capitulum. Some people might spell that capitulum, but we know.
That's what we learned.
Oh, really? When did you learn that? In anatomy? You guys learned this, capitulum? Not capitellum? Okay, well, just know that you're going to see this spelled two different ways. Did I teach you guys capitulum? Because if I did, that's embarrassing.
To be honest, I've never heard capitulum. I also didn't pay attention to anatomy and phys, so.
Okay, so that was in anatomy and physiology. Okay, no worries. It happens. Anatomy's weird like that. We have different words for things a lot of the time. So, okay. So the capitellum, right, articulates with the radius. Now, here's the deal. Who can tell me, by the way, what nerve provides the vast majority of the motor function at the posterior aspect of the forearm, and it comes off of the radial nerve? What branch is that? The reason why I'm asking that question is because there's only been 4 views of the lecture on obviously the neurovascular pathologies of the elbow with the neuroanatomy and stuff like that. So obviously, what branch? So we're talking about a branch of what nerve?
The PIN.
Yes, Kylie, it's the PIN. And what nerve does that branch off of?
The radial?
Yes, absolutely correct. Yes. Okay, radial nerve. But here's the deal. What's the superficial, or I just almost said it. What branch of the radial nerve provides sensation to the arm? Blech, that's horrible. Okay, posterior herniosseous nerve, PIN. What's the other branch, though? And this is a sensory branch. So this is the superficial branch of the radial nerve. Okay, superficial branch. So if you guys have time over fall break and or you're bored, just jump on and just watch that lecture. Okay. All right. Okay. So here's the deal. What do we call it? Okay. What do we call it when we have compression of the ulnar nerve at the elbow, at the level of the elbow? What pathology is that? Going back to class yesterday. I know you know it.
Is it cubital tunnel syndrome?
Oh, who said that? Who was it?
I did.
Yes, Maddie, it's cubital tunnel syndrome. All right, cool. So it's kind of awkward because I have like you guys like over here, like on the side, and I can't see everybody, like all your faces. So yes, cubital tunnel syndrome. Okay. So, okay, compression of the ulnar nerve. All right, ulnar nerve at the level of the elbow. Okay, this is cubital tunnel syndrome. Where does the ulnar nerve enter the elbow? Where do nerves go to game?
The arcade of Struthers.
Let's go. Yes, the arcade of Struthers. I'm gonna stop making jokes like that, but it's like the best one ever. Okay. Yes, the arcade of Struthers. All right. What about the radial nerve, guys? Where does the radial nerve enter the elbow?
Arcade of Froze.
Let's go. Sometimes you just gotta let that go. Let it go. Okay. Nobody. Okay. That was my joke on that one. All right. Radial nerve, arcade of Froze. Fantastic. Arcade of Froze. All right. What for Froze, or as Bella would say, for horse from yesterday. It's a very creative animal that you drew around on that. It was nice, Bella. Okay. All right. Complimenting you. All right. Here we go, guys. So radial nerve, arcade of Froze. Now, what other syndrome could potentially compress the radial nerve at the elbow?
Supinator syndrome.
Yes. Yes. Supinator syndrome. Fantastic, Annika. Supinator. Hello. Oh my gosh. Yeah, the supinator. I am the supinator. Supinator syndrome. Very good. All right. All right, guys. Last nerve, last little review thing from yesterday, and then we'll jump into stuff for today. Let's talk about that median nerve, though. That median nerve, though. Okay, where does it enter the elbow?
Between the pronator teres and bicep tendon.
Yes. Yes. Okay. Now, ultimately, okay, what's another pathology that we can often see that can compress the median nerve at the level of the elbow? What's that called?
Pronator teres syndrome.
Yes, Nico. So whenever Nico like gives an answer in class, I'm just going to do this. If that's cool. Here, good job. Nice job, Nico. All right. So yes, at the median nerve, pronator teres syndrome. Very good. Very, very good. Who can, by the way, guys, who can tell me, as a matter of review, when we're doing 2-point discrimination on a patient, generally speaking, any diameter greater than what is considered abnormal?
6 millimeters.
Very good, guys. Yes, absolutely. Why would we use something like stereonography in a patient? Like, in what situation would we do that?
If they still have sensation.
Stereognosis actually is what I meant to say before I mispronounced that word. I'm sorry, Bella, can you please say that again?
Basically, if they still have sensation, but there could be a problem like in the central nervous system. Okay.
Yeah, so ultimately, if we still think based on our exam that they have sensory function, right, we can actually use stereognosis as a way to determine that either, yes, there is still some level of sensory function that is present, or no, right? Okay. Excellent. Excellent, excellent, excellent. Okay, good job, guys. Okay, so today, all right, we're going to be talking about basically 3 pathologies. These are the ones that are the most common at the elbow that you're most often going to see. All right, so we're going to be talking about lateral epicondylitis, with an I. All right, medial epicondylitis. Come on. And last but not least, also very importantly, we're going to be talking about Lacertis syndrome. I know my handwriting up here is worse than it usually is, but we'll give it our best shot. And I can spell things for you guys as well. Lacertis fibrosis. All right, it's also called Lacertis syndrome. Okay, friends. So that's what we're going to be talking about today. All right. Let me unshare here, and then I will share some other things. How's Tuesday going for you guys? That's what today is. Going okay? Do you guys, by the way, do you guys have modalities 5 days a week, just like this class? Bro, like, here's the thing, okay? Like, and I think it's a good thing. I don't know what you guys think. I think it's a good thing that you guys have those classes. Kylie's face right now. She's like, I disagree. These classes 5 days a week. I know it's a lot, but ultimately, like, I think we did the math, and I think that would, like, in normal credit hours, I think that would add up to like a 4 or 5 hour class, like, generally speaking, right? You're like, yeah, it would. All right, so let's talk a little bit more about these. Okay, let's actually start off talking about medial epicondylitis, okay? So here's the deal. Okay, medial epicondylitis, okay, also referred to as golfer's elbow or thrower's elbow, right? So ultimately, okay, remember, on the lateral aspect of the arm, we've got tennis elbow. On the medial aspect of the arm, we have golfer's elbow, right? Or thrower's elbow. Okay, so ultimately what happens here, all right, with medial epicondylitis is these are all overuse injuries, right? Now, through obviously repetitive microtrauma, repetitive throwing, all those types of things, we can develop inflammation and essentially tendinosis of the medial epicondylar tendon and kind of the attachments of the flexor compartment, right, to the medial epicondyle. So who can tell me? Okay, who can tell me essentially what do you think happens with medial epicondylitis as far as if I say something like tendinosis, if you guys hear that word, right? What generally comes to mind? If I say like a tendinitis or like a tenosynovitis, how would you compare and contrast that to something like tendinosis? What do you think?
The severity of the inflammation.
Okay, severity of inflammation. One thing that we might often see as well, right, with tendinosis is actually also breakdown of the tendon, right, and of the sheath to the extent where the tendon sheath and the tendon actually adhere to one another, right, in certain locations. And so we have this kind of diffuse inflammatory process that takes place, right, at the side of the medial epicondyle. And so ultimately, in some cases that could actually even lead to rupture of the tendon. Now, here's a quiz question for you though. Okay. In the event that we are doing this assessment on maybe a thrower, maybe we've got a pitcher in front of us that's between the ages of 13 and 16, maybe even 13 and 17. What else would we words. What else would we need to be cognizant of with this patient? What do you think?
Growth plates.
Okay, Annika, growth plates, absolutely. So you said growth plates. Explain to me a little bit more why we would worry about that. I mean, it makes sense, but why does it make sense to you?
So I'm just kind of comparing it to my little brother. He's 13. He broke his wrist this summer.
Yeah.
And one of the big things we worried about was his growth plates, just because we don't want the finalization of the process to cause any deformities with longer term effects.
Yeah. So ultimately, right, and a lot of adolescents as well, right? Generally speaking, tendinopathies, and we see this most commonly we see this in like patellar tendinopathies, particularly Osgood-Schlatter, where the muscles actually grow and become stronger at kind of a quicker rate, right, than the tendon can keep up with. And we actually pull excessively on the open growth plate of the tibia, and that causes inflammation actually at the tibial tuberosity. And so ultimately, though, the involvement of growth plates is a very, very, very common problem, particularly in pediatric athletes. So always be on the lookout for that with medial elbow pain, particularly in adolescents. Always have that at the back of your mind. Okay. Ultimately, though, right, as these tendinopathies continue to develop and progress, particularly if they go untreated, they can actually start to calcify. So calcific tendonitis is actually a complication of medial epicondylitis and even lateral epicondylitis, where we can actually get calcium deposits actually in the tendon itself. Okay, so that is not, it's definitely not uncommon. All right. Okay, so let's actually talk about, let's actually kind of talk about the clinical exam here. So ultimately, what do you think, all right, is going to cause most of the pain, particularly on clinical exam with these patients? What do you think will be provocative?
Probably flexion or pronation.
Okay, so yeah, so we could say that, you know, flexion will definitely probably be will be provocative of symptoms. So obviously, if we, you know, and this is just, it's real simple wrist flexion, right? Resisted wrist flexion. Does that or does that not reproduce symptoms? Obviously, particularly if this is an overhead athlete, what else would you include in your exam? What else would you, what else would you do?
Look at the shoulder.
Okay, yeah, definitely look at the shoulder, right? So we mentioned a little bit, you know, we were talking about regional interdependence the other day in class and talked about the importance of assessing the shoulder. But what other thing, then you're definitely right, Justine, what other thing would I need to rule out or at least pay attention to before just simply labeling this as an overuse pathology? We learned how to do an exam for this in class the other day.
Would it be looking at the UCL?
Yes, look at the UCL, look at the medial elbow, okay? Make sure, okay, if they've got symmetry bilaterally, make sure that they're not lax, make sure they're not having symptoms into the ulnar nerve distribution, all right? Make sure they're not tender at the joint line, okay? All right, I'll give you guys a second. Gotta let the dog out. Let's do this. All right, guys. Okay, so ultimately, resisted wrist flexion is often going to be painful for these patients, but obviously also we're going to need to also make sure that we're checking the UCL, and then obviously make sure that we're able to rule out any neurological symptoms into the hand and fingers. So ultimately, with any inflammatory process. We're going to use our standby of obviously rice, rice ice compression elevation, maybe use of anti-inflammatories. One thing that might be useful in these situations, obviously, and Justine, you're absolutely correct, targeting the shoulder, because we're going to, in the PowerPoint and like in the voiceover lecture that I put together for you guys, we're actually going to look at a study where a lot of overhead athletes that actually have elbow pain also concurrently have shoulder pain. And you'll see those things presenting simultaneously. So it's very, very important to look at both, right? And that makes sense to you guys, right? Okay, good. All right. Okay, friends. Let's move on. Let's actually talk a little bit about Lacertus syndrome. Okay, kind of in a similar, anatomical region, but okay, this was originally identified in 1959. Okay, but let's actually take a look at the anatomy of the Lacertus fibrosis. Can you guys see this, by the way? Yeah, sweet. Okay, so the Lacertus fibrosis, like we talked about in class. All right, check this out. So here we go. I'm going to zoom in on this a little bit. Perfect. So we see the bicep actually coming down here, okay? And there's the bicep tendon. But then just medially to this, okay, we can see that the Lacertus actually comes in kind of medial to that bicep tendon down here distally. So here it is, all right? And so we have this big, thick, right, band of fascia coming off the bicep tendon. Now look what else actually travels through here, right? So we have the, obviously bicep tendon, but also the median nerve. Okay, here's the pronator, bicep tendon, median nerve coming right through. All right. Now, oftentimes, that when I was at TRIA, often what we saw, we had patients that would come into our hand surgeons to be treated for carpal tunnel. Often what our hand surgeons would also do, in addition to releasing the carpal tunnel, they would actually also go in and release the Lacertus. They'd actually go in and actually just kind of release this Lacertus fibrosis away a little bit to kind of take pressure off of the median nerve at the elbow as well to alleviate symptoms. Okay, so, all right, one sec. Okay, so one of the things that we often see, okay, particularly in overhead athletes, is that over time, okay, check this out. So if you're swole, particularly like this guy, and you're a thrower, you can actually see the Lacertus actually, because it's thickened up so much, actually develops a nice little kind of indentation between essentially the pronator and the medial compartment. You can actually see that coming right off the bicep tendon, right there. Okay, so ultimately with throwers, it's going to be really important to not only palpate this, to kind of be able to appreciate the thickness of the Lacertus fibrosis, right? But also looking for any signs of indentation, which may indicate that the Lacertus is really, really thickened and potentially compressing the median nerve and other structures, right? Okay, check this out. One of the things that they actually discovered with, kind of looking at pitchers as they were studying Lacertus syndrome, is that this is actually a lot more common in pitchers that seem to throw curveballs, that throw a lot of breaking balls, right? And they don't necessarily, and so that was always something that for me, like particularly when I was a young athletic trainer and just was kind of working, that was a connection for me that was difficult to make, at least initially, as a new clinician. But it definitely does make sense, because I was never taught in school that the Lacertus fibrosis could actually even thicken. I was never even taught that the Lacertus was there, right? To even, be something to consider. So just something to kind of be aware of. Okay. All right. So ultimately, too, with Lacerda syndrome, it's not uncommon to, kind of also hear these people complaining of tightness, complaining of things like swelling and stuff like that in the arm. How many of you have seen exertional compartment syndrome in the lower leg before in a patient? Do you guys know what that looks like? Okay, Justine, you're raising your hand. What did that look like for you in the patient that you dealt with? Tell me a little bit about that.
I didn't deal with it super closely, but there was a track athlete last year who had it, and I know it just was very painful for him, and he like still participated, but like after any race, like it was just immediate like ice everything.
Yep.
Like lots of pain and issues, and he was really worried about it coming back this year.
Yep. So ultimately, yeah. And so ultimately, it's kind of similar. It's almost kind of like a miniature compartment syndrome within the elbow. So ultimately, like we talked about, right, within the cubital tunnel, and particularly in the space between the pronator biceps and Lacertus, there is not a lot of room for fluid to accumulate. So the more swelling due to microtrauma and those types of things that actually, develop within that area, symptoms can actually be a little bit more severe as well. So kind of going back down here. So ultimately, okay, here's a question. Okay, knowing what we know about regional interdependence, all right? I see like people sighing. I know, guys, it's Tuesday. So given what we know about regional interdependence, how would you guys potentially treat something like this? We've already talked about looking at the shoulder. What would you do for someone with this type of a problem? How would you treat it?
I don't know if it's just me, but I can't figure out how fascia is related to like regional interdependence in terms of more of that was, I thought, like joint wise.
Say that one. I'm sorry, Bella. Say that one more time. I caught part of what you're saying.
How is a fascia related to interregional dependence? I thought that was more like joint relation versus.
Okay. Definitely a fair question. Okay, definitely can be. Now, here's the deal. If you think about throwing mechanics, okay, if I'm an overhead athlete, okay, and let's say that I've got, posterior capsular tightness and I'm throwing, okay. If I've got a lot of posterior capsular tightness and a lot of kind of tightness in the posterior and inferior shoulder, where do you think, okay, obviously, if I've got altered humeral position, what do I have less of as far as muscular activation at the shoulder? I've got less activation of my cuff, right? Why do I have less activation of my cuff at the shoulder? Because of the altered position of the humerus in the glenoid, right? So in somebody with posterior and inferior capsular tightness, the humeral head shifts, like we learned about, superiorly and posteriorly, right? But then additionally, the bicep, remember, crosses two joints. Okay, it has the long head, right, inserts on the supraglenoid tubercle, right, and the short head inserts on the coracoid, but it also comes down and inserts on the radial tuberosity at the elbow. So ultimately, Bella, you can see that as I'm actually extending and throwing, that is the bicep actually lengthening or is it shortening as I'm actually following through and throwing? What's happening?
It should be lengthening.
Should be lengthening. Okay, very good. Yes, absolutely. But as it's lengthening, okay, as it's lengthening, how does that affect the amount of stress, right, on the bicep tendon? And by extension, because the Lacertus comes off of the bicep tendon, or yeah, on the Lysertis because it comes off of the bicep tendon.
It increases it.
Absolutely. Because in order to slow my arm down, okay, the bicep has to turn on and contract at a higher rate eccentrically to stop the velocity of my arm. Okay, to slow the motion down at the elbow. I can see that that's clear as mud, but does that make sense? Yes or no? And if it doesn't, I will explain it further or try to explain it differently so that it's clear. We're like, yeah. Josh is shaking his head no.
I don't know if it's my brain just not firing on any cylinders today, but it's not really clicking.
Okay, all right. So here's the deal. So ultimately, when I flex my elbow, okay, I'm contracting concentrically. All right. If my elbow is extending and it's doing so at a very high rate of speed, okay, obviously the primary restraint there is going to be, right, the elbow joint itself, the ulna and the humerus, right, in full extension. But if you can imagine, if my elbow is constantly extending and hyperextending at a high rate of speed, how long will that joint last before it becomes injured? Not very long, right? So what's necessary in order to slow down the speed of the arm in full extension? The bicep has to essentially turn on and lengthen, right, to be able to slow the arm down in space, right? It has to essentially create an eccentric contraction to decrease the velocity of the elbow. So I can explain more. I can explain that more tomorrow in class, more together. Okay, we can go over that as review. Okay. Okay. Cool. So obviously you can see where they go in, sometimes surgically, and they actually correct this. So they've actually gone in here and they've actually kind of resected the Lysertis. They've actually released it. Okay, and sometimes that can actually provide pretty complete relief of symptoms. All right, lateral epicondylitis. Here we go. Okay, so lateral epicondylitis is going to be really, really common in overhead athletes, particularly tennis players. Okay, why do you think that a tennis player might develop lateral epicondylitis? So if I'm hitting a backhand, okay, if I'm hitting a backhand, look at the position of my wrist. Okay, it's repetitive extension at the wrist. And so lateral epicondylitis is extremely common, not only in overhead athletes, but also in tennis players as well. We often also see this in people that, like day laborers and those types of things that do a lot of like activities where they're constantly having to lift things like this with their wrists. Very common in painters, roofers, people like that. We saw that a lot at TRIA with people that would come in that had labor type of jobs as well. So, all right. So with this type of tendinopathy, right, we're typically concerned with the tendons at the lateral. I'm actually going to draw this with the lateral aspect of the elbow. Okay, so extensor carpi radialis, longus and brevis. All right, so here's my elbow. All right, and here's the attachment point. Okay, extensor carpi radialis, brevis. Okay, now, and there's my wrist. Okay, the more that obviously that I extend the wrist, okay, over time, that's actually going to put a lot of stress on the attachment site at the tendon, particularly when I extend the wrist against resistance. So generally speaking, people with lateral epicondylitis are going to have pain with resisted wrist flexion. That's going to really, really bother them quite a bit. Okay, so look for pain with resisted wrist flexion. When you're examining someone, that's pretty much exactly how you will elicit those symptoms. Also not uncommon for them to be very tender at the attachment site, okay, at the lateral epicondyle, and then even distally along the lateral aspect of the ulna as well. Okay, right here, not uncommon. So ultimately, you know, there are different ways that we can treat this. So we can use straps. Okay, they do make straps to treat this. The other thing that we can also do is obviously we can focus on regional interdependence, treating the shoulder as well. I had a tennis coach one year that dealt with lateral epicondylitis quite a bit, and also probably within the next year ended up having rotator cuff surgery on the same side, right? So there is a lot of essentially a big relationship between the shoulder and elbow, particularly with these types of pathologies. Okay, you know, dry needling, stretching, all those types of things are things that can be indicated with these types of things. So if we continue, if we just kind of look here though, okay, kind of scroll along down here, show you this. Okay, this is the wrong paper. I'll put that in the PowerPoint though. Okay, so all right, lateral epicondylitis, right? Typically pain over what anatomical landmark are we typically going to see? Okay, I think I heard Bella try to say something, but I think you were muted.
I was just saying the lateral epicondyle.
Right. Okay, does that make sense though? I mean, these pathologies are not entirely all that difficult, right? But tomorrow we can talk more about regional interdependence as it applies between the shoulder and elbow, and I'll address that in the PowerPoint too that I record for you guys. Okay. All right. So just a heads up before you guys head out for fall break, we're not having, and I know you guys know we're not having class on Friday. I am going to throw up just a quick Moodle quiz for tomorrow. So that'll just go ahead and knock that out for me, 5 questions. Okay. And we'll get that done. And then you guys can have a good fall break. Is there anything that we've covered so far that's not clear? Anything that you guys feel that we need to do a little bit more of a deep dive into, cover in greater detail, that I need to further clarify before we call it a day, at least for this class? No? All right. By the way, if any of you showed up last night for Review Shetson's litter and I was not there, I was there for about an hour and then didn't see anyone, so I left. But there were a couple people that showed up later in the evening. So if I missed you, I'm sorry about that, and we will fix that for next time. So, okay. If you guys need anything, let me know. You guys are rock stars. Okay, keep doing what you're doing. You guys are doing great. I will see you guys tomorrow in Class A. Okay, face to face. And okay, have a great day, and I'll see you guys tomorrow. Bye, guys.